Please listen carefully.
Hello and welcome to GasGasGas. This is the best podcast for the FRCA primary exam. Our goal is to fill your brain with all this highly useful information. You might be in the gym right now, commuting, or ironing your scrubs. Regardless, the revision is eventually going to end, but for now, expect facts, concepts, model answers, and the odd tangent. Make sure to check out gasgasgas.uk. The show notes there's loads more detail. Make sure to like and subscribe. Anyway, buckle up, get ready for your mind to be bent into a new shape, and let's get on with the show. Hello everyone, this is James at GasGasGas. This is another episode of the Local Anaesthetics series, and I'm sure you've all been super excited, absolutely waiting for it, because today we are talking Lidocaine. Before we get into the bulk of the show, we're doing a series on all the local anaesthetic agents. We've done an intro to local anaesthetics, we've covered bupivacaine, cocaine, and the last episode was prilocaine. So if this is your first time listening to GasGasGas, make sure to go back and touch on that introduction to local anaesthetics episode as well, because it really does set the scene for everything you need to get on with. Now, if you're finding this show absolutely riveting and you think, yeah, Dr. Gas works really hard and I'd like to show my appreciation, feel free to click that donate button at the bottom of the show notes and fire off a couple of £1 million. That'll be very nice of you. Thank you very much. Right, Lidocaine. So we're going to go through all the data and then we're going to talk about a few interesting points. So its name is Lidocaine. Its brand name was Xylocaine, and you might hear that being bandied around. And also historically it was called Lignocaine. So it's got three names. But what it really is a local anaesthetic agent or a class 1B antiarrhythmic agent in our Vaughan-Williams classification of antiarrhythmics. Because if you've got no amiodarone somehow in your hospital, which is a situation that wouldn't be completely unlikely in the current state of healthcare in the UK, you can reach, as per ALS guidelines, for lidocaine in a VT or VF rest situation. Although I'm sure you'd instill terror into everyone around you if you were reaching for that. It's a tertiary amine, therefore it's an amide local anaesthetic agent, and for all those die-hard delighters of pharmacology, it is derived from diethylaminoacetic acid, which just rolls off the tongue quite beautifully. It is a clear, colourless solution. It comes in a number of concentrations, classically 1 or 2% solutions, plus minus 1 in 200,000 adrenaline. However, we all know that lidocaine is superbly pervasive in our practice. It comes as an ointment, 5%, a 10% spray, a 4% aqueous solution for topication, and also it is found in Instilogel. Instilogel is 2% lidocaine and chlorhexidine, so it sterilises, anaesthetises, and lubricates. Great. But also you get a 5% spray with 0.5% phenylnephrine. It also comes in lidocaine patches. These are patches about the size of your hand that are classically used in rib fractures. Now, whether or not they actually convey any benefit or they just entertain us and the patient whilst we scrabble around until we start PCA or stick a rectus spinae plane block in or epidural in is another question. I don't think it actually gets that deep and therefore probably doesn't really help unless someone is skin and bones. Then maybe it might help a little bit. I think it might have been Voltaire who said the role of a doctor is to entertain a patient whilst the disease takes its course, and I feel that is where lidocaine patches in rib fracture management really comes in. It's just something to do and we shouldn't do that really. Anyway, but I don't know the evidence, so I'm going to ramble, so I'm going to move on. So the next logical cognitive step you need to take is, gosh, if it comes in so many different shapes, forms and preparations, including EMLA, then it must have a painfully extensive range of uses which you could therefore be asked about in an exam, and you're not wrong, and we'll get to that in a moment. To tidy up and finalise that, we definitely need to all know that it has a molecular weight of 234 grams per mole, which seems to be in the same sort of ballpark as all these other amide local anaesthetic agents actually. And we all know the mechanism of action of local anaesthetic agents now, and if you don't, I'm going to tell you, but clearly you need to go and listen to those other episodes as well. Local anaesthetic agents act upon the internal aspect of a sodium channel in a nerve axon, therefore it has to get there. It will only transition across the plasma membrane of the neuron in its unionized form. So therefore you've already got a fraction of that agent which works whilst the other fraction does not, so to speak. That's based on the pKa of the drug. There's an episode on pKa if that has left you surprised. It's early on this podcast journey that we're all on together. Once that local anaesthetic agent is inside the nerve cell, its journey is yet to finish because it then needs to return to being ionized or becoming a cation. It It does this generally by binding to a hydrogen ion inside the nerve. And then our fortunate local anaesthetic agent in its ionized form on the inside of the cell finally binds to that sodium channel. As a little additional aside, it tends to like to bind to channels that have been activated because it's more pleasingly shapely for said local anaesthetic agent. This is what we describe as use-dependent block, and actually if you stick some local anaesthetic around a nerve and then try and use it, you generally result in a slightly faster onset of action. As an aside, I'm super excited to learn about how many different ways I can describe the mechanism of action of local anaesthetics with greater and greater verbosity. So keep tuned for all that. Clinical uses of lidocaine are extensive, as we mentioned earlier. You can infiltrate it under the skin. You can use it for regional nerve blocks, epidural top-ups, field blocks or ring blocks, airway topicalization, urethra topicalization, and also intravenous infusions for pain control. And don't forget, as an IV bolus with a dysrhythmia, although that's a bit niche. As with all local anaesthetics, there's a maximum dose, and then there's some recommended doses depending on where you're putting the lidocaine. And as we all know, absorption of local anaesthetic agent is dictated by the vascularity of the space, as well as the particular properties of that local anaesthetic agent, i.e. how soluble it is, how much protein binding it can undergo, if it is inherently vasodilatory in itself or not. Cocaine being a vasoconstrictor, whereas bupivacaine tends to cause some capillary vasodilation. But before we talk about all those doses, how long does it take to work? Well, lidocaine is quicker than bupivacaine, and it depends on what you're blocking as to the onset time. If you're sticking a bit under the skin to numb up an area for a blood gas, and I would implore everyone to use lidocaine whenever you're doing an arterial blood gas, your patient will thank you, and it just makes your life easier. Tell all the new F1s, use some local anaesthetic. It'll make it less challenging for you because the patient won't be writhing in agony as you're trying to dig around and find that artery. Use local anaesthetic for arterial blood gases. Well, that was another digression. The onset time, if you're trying to block the very fine and minimally myelinated nerves in your skin that are detecting pain and pressure and vibration and cold and all that jazz, the onset time is really quite fast, maybe even like 20 or 30 seconds. Very easy to test. If you're blocking a nerve, it takes about 3 to 5 minutes to work, and that's because if you imagine the nerves in distal skinny tissues, you're going to be in the situation of those fine nerves that have not very much in the way of myelin sheath, etc., etc., whereas big chonking nerve that's quite good at conducting and is very busy conducting robust signals around with a nice thick myelin sheath takes longer to numb up. How long does it last? So plain lidocaine, i.e. sans adrenaline, 90 minutes to 3 hours, probably depending on how much you've stuck in and how vascular the site is. Lidocaine with adrenaline, you're talking maybe 4 to 5 hours. So what about doses? Neat lidocaine, do not use more than 3 milligrams per kilo. That means for a 75 kilo patient, 22.5 mils is your max dose of 1% lidocaine. So you shouldn't be using more than 4 or 5 mil ampules in a normal, approximately normal sized human. But if you're needing to use that much lidocaine to numb someone up for a central line, are you sure you're definitely not just being handed normal saliners? And then with adrenaline, you can get away with more than double that at 7 milligrams per kilo of lidocaine, which is cracking. Now, I'm not going to break down all the different doses of where you can put lidocaine in what amount to achieve what effect. If you're really interested in that, there's a summary of all that in the show notes, because I don't really want to get bogged down in telling you a load of numbers all the time. Why don't we stick it in spinals? Because it causes those transient neurological symptoms we spoke about in the Prilocaine episode, and it's the chief offender of that, so it'd be mad to use it for a spinal anaesthetic. Can you make lidocaine work faster? Yes, you can add sodium bicarbonate to your lidocaine mix. That alters the pH of the agent, but also alters the pH of the tissue you've injected it into, increasing the unionized fraction of lidocaine, subsequently improving onset. You might be able to just about get away with sticking a bicarby lidocaine mix in and around an abscess to numb it up sufficiently, but as we know, the pH of the tissues around an abscess is more acidic, and therefore there's a smaller unionized fraction of lidocaine, so you just find yourself not really winning, but you can give it a go if it's small. As with everything, when we're talking pharmacodynamics and we've tapped on dose and route and purpose, we need to think about side effects. So we're always in the exam, we're going to be breaking down side effects into their systems because it helps us remember, but also the examiner will probably start falling asleep if you start quietly reaming off a very neat and structured approach to this bit of your conversation. So cardiovascular side effects stand more or less the same as the other local anaesthetic agents. It decreases the rate of rise of phase 0 of the cardiac action potential by blocking sodium channels. If given enough, you end up in the world of local anaesthetic toxicity, and this will lead to a plethora of dysrhythmias from VFVT to asystole. Don't give too much local anaesthetic, folks, and don't stick it in someone's vein or artery. Low toxic doses lead to a slight increase in systemic vascular resistance. However, once you're in the high dose territory, you will drop that systemic vascular resistance, and obviously it has negative inotropic effect. Respiratory perspective, interestingly, lidocaine is a bronchodilator at subtoxic doses, but trying to shoehorn that into a conversation about life-threatening asthma probably will raise some eyebrows, because there's a number of other lower hanging fruit options for drugs in asthma until lidocaine. I don't think anyone's used that. Naturally, in toxic doses, you're just going to anaesthetize that respiratory center and you're going to get respiratory depression. The CNS side effects, again, we've mentioned this before, but it's biphasic. So you get an initial excitatory response. Patients get lightheaded, dizzy, they get visual and auditory disturbances, they get that tingly mouth or circumoral tingling. And then in higher doses, you end up with progressive sedation of the brain, leading from being dozy and confused and disorientated to a coma. Somewhere between these two stages, you might also see a seizure, which is a fairly common element of local anaesthetic toxicity, and you should either treat that with benzodiazepines or propofol. Intralipid technically won't treat the seizure, but would treat the toxicity, but propofol is fair game, or thiopentone in that situation. I'm getting ahead of myself. GI side effects, it depresses your bowel contractility, and that's because it's going to anaesthetize your enteric nervous system. Ta-da! You can work this all out, guys, on the fly. For other or interesting, allergic reactions to amide local anaesthetics are very rare. You're more likely to have an allergic reaction or rash-like reaction to ester anaesthetics. Lidocaine can cause methemoglobinemia, much like prilocaine, although I think rarer. So if you've got a patient who's predisposed to that or on other drugs that might predispose your patient to methemoglobinemia, perhaps large doses of lidocaine wouldn't be a smart move. Now, the other interesting side effect situation of lidocaine with adrenaline depends on if you're sticking it into a relatively vascular area. So it's seen in neurosurgery, where they are numbing up the scalp to slice into it with lidocaine plus adrenaline to try and impair how much blood starts pouring out the scalp, because it is just a very, very vascular place. But what you get is systemic uptake of adrenaline, and because it's in relatively low concentrations, you see an interesting set of autonomic nervous system mediated responses. So actually you get a drop in blood pressure as that adrenaline starts soaking into the person, because adrenaline tends to like beta-1 adrenoceptors, which cause vasodilation and tachycardia. So you get vasodilation, which is a drop in blood pressure, plus a tachycardia. Patient looks a bit ropey, and then you get a subsequent improvement in blood pressure, courtesy of adrenaline now tickling those alpha adrenoceptors well. And that is just cool, isn't it? So the pharmacokinetics of lidocaine, absorption-wise, well, it really does depend on where you've gone and injected it, squirted it, or sprayed it. That same old string of words applies. So from most absorbed to least absorbed would be intercostal, caudal, epidural, brachial, subcutaneous. But we also know that we stick it into a lot of other places. So if you spray it into someone's airway, down their trachea, the uptake is actually quite rapid and you hit quite high peak concentrations. So you definitely need to be thoughtful about how many sprays of local anaesthetic of what concentration you are administering to someone's airway to sufficiently numb it up. That is beyond the scope of this episode. Distribution. So its pKa is 7.7 and it is 25% unionized physiological pH. How do you remember all these pKa's? Well, you need to figure out some sort of complicated system yourself, but I just think that lidocaine starts with an L and a 7 looks like an L backwards. So therefore the one that is 7.7 must be lidocaine, which is a long-winded way to try and remember a pKa. It is 64 to 70% protein bound, and again, it is chiefly friends with alpha-1 acid glycoproteins, and it has quite a small volume of distribution, actually 0.7 to 1.5 litres per kilo. How is it metabolized? Well, you rightly ask that, and you know the answer, because it's an amide, so it's metabolized in the liver by N-dealkylation, and it's hydrolyzed then into something called monoethyl glycine and xylidide, and there is some rumbling suggestion that these metabolites might drop your seizure threshold, but again, I think you'd be having to give quite a bit of lidocaine to achieve that. 10% is excreted unchanged in the urine. It has a clearance of 6.8 to 11.6 mils per kilo per minute, and its elimination half-life is 90 to 100 minutes. So that was a whistle-stop tour of all the blurb of lidocaine. Could you get all of that out in an exam? Probably not, but if you can have a structured approach to talking through any sort of drug in this sort of manner, you're going to be halfway there, folks. Now for the interesting part of the episode, is thinking about this malarkey with IV infusions of lidocaine to treat pain, because what I've told you is that lidocaine can be toxic, it has loads of side effects, and actually it bears out with pain infusions as well, because there's a narrow therapeutic window and there's a lot of variability between all your patients as to how they metabolize it, how much free lidocaine is in their plasma, and if you inadvertently under or overdose them. There's a great article from the AAGBI that's like a consensus statement built on oodles of meta-analyses, etc., to come to some sort of sensible conclusions. But in terms of dosing, so if you're doing this, you'd need to dose it on ideal body weight. Now, you might be asked how to calculate that in an exam, and it's simply the patient's height in centimetres minus 100 if you're a man and 105 if you're a woman. If the patient's less than 40 kilos, don't do a lidocaine infusion. And then there are some cut-offs for how much you should infuse per hour. So no more than 120 milligrams per hour infused. Now, if you're using 1% lidocaine here, which is 10 milligrams per mil, that means that the infusion rate can't be any more than 12 mils per hour, and that's regardless of weight. How do you dose it if you're venturing off into this unknown realm, which I think is fairly common in some centres and then completely uncommon in other centres? But you load the patient over 10 minutes with 1.5 milligrams per kilo of lidocaine based on their ideal body weight, and then you start an infusion of 1.5 milligrams per kilo per hour. They recommend in this consensus statement that you shouldn't really be doing this for more than 24 hours. There's some other caveats they mentioned. So outside of the theatre complex, a patient on a lidocaine infusion should be in a monitored bed space. Lipid emulsion should be readily available. That seems very common sense. And that you shouldn't be mixing and matching a lidocaine infusion with a multitude of other local anaesthetic nerve blocks, and that you should wait 4 hours before starting an infusion if you've done a block or port site infiltration. But single shot spinals are less of an issue because that's such a small dose. Fortunately, the effects of a lidocaine infusion persist for a fair time after cessation of that infusion. So why on earth does lidocaine, which blocks sodium channels, somehow treat pain? And they actually purport that it is an anti-inflammatory, mitigates hyperalgesia, and is an analgesic. So lidocaine blocks muscarinic receptors, M1 and M3, blocks our friendly NMDA receptor, which we know ketamine likes, but also our dear friend methadone likes to block the NMDA receptor. And in really high doses, lidocaine blocks a load of other stuff, which I've never heard of, which I'm not going to tell you about. But if you give enough of any drug, then it'll start shoehorning its way into receptors that it doesn't tend to quite fit in, because there's just so much floating around. So do lidocaine infusions work? This consensus statement kind of returns to the fence and says, in the gist of it, the heterogeneity of these papers and the resultant meta-analyses leave ultimately a lot to be decided, because there's so much variability between all the papers, and it is not clear if it does have a distinct benefit. Are the infusions safe? Well, unfortunately, symptoms of toxicity don't correlate to plasma concentration. That's one headache. And there are a number of variables that influence that free fraction of lidocaine in the plasma, which is the fraction is up to mischief, because it's bound to glycoprotein and maybe a little bit of albumin in the plasma. It depends on the patient's cardiac index, because if they've got a high cardiac output, then they're going to clear more through their liver. If their cardiac output is low because they're sicky poorly, then they're going to accumulate more. If they're a bit acidotic, or they've got a bit dozy and stopped breathing sufficiently, then an acidosis shifts more lidocaine off of plasma proteins. If the patient is beta blocked, it can reduce lidocaine metabolism, and as you might expect, lidocaine plus amiodarone are going to lead to some cardiac mischief. That's not recommended. They do go on to say that across the board, the studies that they've reviewed, most of the catastrophic events actually bore out human error in dosing calculations than a perfectly organised and appropriately dosed lidocaine infusion. So we are our own worst enemies, as always, folks, and we should never rush when we're doing maths, and we should never allow ourselves to be distracted when we're drawing a drug. We should create that silent cockpit that they talk. My singular and last thought on that is lidocaine a prevailing punter for a Eleveld-esque TCI model? You just tap a patient's detail and the machine doses the patient appropriately. Wouldn't that be great? One day. So you might now actually be listening to this episode, and this is the first Gas episode you've listened to, and welcome if you have. You should definitely go back and listen to some other ones. So I'm just going to quickly remind everyone about the key points of local anaesthetics to remember. Onset and length of action are dependent on the pKa, the solubility and protein binding of the drug. As you can imagine, a large unionized fraction and high solubility yields a rapid onset, and if there's robust protein binding, you tend to see a longer duration of action. The compounds themselves would be described as amphipathic compounds, which is a bit of a mouthful, but it goes to describe that there's a hydrophilic end and a hydrophobic end. And in the exam, you might get asked to describe the overall structure of a local anaesthetic molecule. The fat-loving hydrophobic end is a benzene ring, or a lipophilic aromatic ring, whereas the amino group on the other side of the molecule is the more water-soluble element of that molecule. And then they are joined together by either an ester or an amide linkage. We know that ester local anaesthetic compounds break down quite quickly because of plasma esterases that go around mopping things up at a howling speed, whereas amides need to be tottled off to the liver to be broken down. Now, my final gas top tip of the day, alongside you should use it for ABGs and encourage everyone to do the same, is that if you've got a patient who is really not terribly keen on an NG tube because it feels like someone's trying to jam a copper pipe down their nose, which it probably does feel quite awful, especially if you're very hypersensory and overstimulated, having been fiddled around with, operated on, feeling like you're half dead. No one wants an NG tube shoved up their nose. So the solution, the bargaining chip, as long as your patient isn't obtunded, is to use lidocaine with phenylnephrine in it. It's called cofenylcaine. Theatres should have it. It comes in a little blue box, and you prep it together and you squirt it in their nose a couple of times. You get them to sniff a bit so that hopefully it numbs the back of their throat attach and let it cook. You end up with a patient with a numb nose, but also that vasoconstriction created a bit more space in their nose, and therefore you can sneak that NG tube down with less of that gibbering discomfort and agony. Now, if you go a bit overboard with the lidocaine spray, you might numb up their oropharynx a bit. They might end up becoming a bit discoordinate when you're trying to get them to swallow. And much like if you topicalised an airway, they shouldn't be eating or drinking for the next hour or two afterwards, because they're less able to prevent it going down the wrong way. But if you've got someone who's had a rotten time and they really need an NG, and everyone's saying, oh, so-and-so needs an NG, but they don't want it, blah, 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 you can go in and say, hey, I can make it quite a bit more comfortable. Shall we give it a go? Right, well, I've talked far too much, as always. I hope you enjoyed that episode, guys. Next week, we are covering the other ester local anaesthetic agent. I'm sure we might talk about topicalising eyeballs, and not with cocaine, because we know that's not very good. Anyway, I hope you have a nice week. Check out the show notes. There's a couple of useful links on there about methemoglobinemia and lidocaine as a pain infusion, as well as a link to the godly Bible of all things intensive and anaesthetic medicine flavoured, the deranged physiology local anaesthetic pharmacology page, which is a dreamboat. There's also a link to a Bayesian network meta-analysis, which is a mouthful, looking at which local anaesthetic agent yields fastest onset for epidural anaesthesia for emergent caesarean section, because some places use a confusing mix of lidocaine, bicarb and adrenaline, which yields a rip-roaringly fast onset time, whereas most places I've worked just stick 0.5% bupivacaine in, but start topping it up in the delivery room as you transfer to theatre. I'm getting carried away again. Have a nice week. I'll see you next time. Cheers! Thanks for listening, guys. I hope you found it useful, but if you found it awful, do let me know. Please like and subscribe, register with whichever podcast platform you find yourself using, and leave a comment if you think I need to square something away. I just want to make sure that you guys know that every day you are getting better at this. There is a bucket of content to try and consume, and it is like drinking from a fire hose. Take it day by day, don't overcook yourself, don't freak out, and keep studying.